Imagine you're looking at a brain scan, right? And instead of the usual branching network of healthy blood vessels, you see something that looks like a string of pearls just scattered across the cerebral arteries.
Yeah, it's a very striking image.
It is. And for decades, doctors looked at that specific beaded pattern and made this massive assumption. They assumed those vessels were, severely inflamed, structurally deteriorating, just actively failing.
Right, but they were wrong.
Completely wrong. Those vessels weren't inflamed at all. They were actually experiencing a violent, chemically induced spasm.
It's honestly one of the most fascinating misinterpretations in modern neurology, I think.
Yeah.
And it perfectly highlights how tricky this diagnostic landscape can really be.
Yeah.
Because we like to think of medical imaging as an objective truth, but what you see on the screen is, often just a shadow of a much more complex physiological reality.
Absolutely. Well, welcome to today's deep dive. We have a massive stack of sources on the table today. Medical literature, pathology reports, historical pharmacovigilance data, all to help us. And you listening, unpack the very real, very complex mechanics of intracranial hemorrhages.
It's a great topic.
And it's actually the perfect time to dive into these sources because we have an official update on case file 004, which we've been tracking for a while.
We do. And for that particular patient, the mystery is officially solved.
Finally.
Yeah, her toxicology screen came back completely negative. So that confirms her bleed was caused by exactly what the initial presentation pointed to, which is a combination of warfarin therapy and underlying amyloid angiopathy.
Right, so just a textbook case of fragile protein deposits in the vessels, combined with the systemic blood thinner.
Exactly what we expected.
But today, we are sort of flipping the script. We're taking this stack of pathology reports and we're looking at the outliers. What if that toxicrene hadn't been negative? What if the patient was young, structurally healthy, and had literally zero history of high blood pressure? Today is all about the imposters and the chemical hijackers of brain bleeds.
Because understanding these non-hypertensive causes is critical. A hemorrhage isn't just a hemorrhage,
Yeah.
Whether we're dealing with systemic inflammation or street drugs or even historical over-the-counter medicines or just sheer physical trauma, the underlying mechanism really dictates everything.
Right, they look different on a scan, they behave differently clinically, and the medical workup required is just entirely distinct.
Exactly.
Okay, so let's get into the mechanics of this. I want to start by looking at intrinsic failures. Specifically, when the body's own immune system just goes rogue.
Okay, vasculitis.
Right. If we rule out chronic hypertension and amyloid deposits, and we see a brain bleed driven by vascular inflammation, we are talking about CNS vasculitis.
Precisely. And it's a rarer cause of intracranial hemorrhage, but it's structurally devastating when it happens. In the literature, you generally need to separate this into two distinct clinical entities. Okay.
The first is granulomatous angiitis, which is often referred to as isolated CNS angiitis.
And the pathophysiology here is what makes it so aggressive, right? Because we're looking at a very specific type of cellular infiltration.
Yes. So if you look at the histology, you see this intense mononuclear inflammation.
Oh, right.
Complete with giant cell formation. And this isn't just like a surface level irritation. These inflammatory cells are infiltrating deep into the tunica media and the adventitia.
So that's the muscular and outer layers of the vessels, right?
Exactly. The small and medium intracranial arteries and veins.
So you have this aggressive inflammatory cascade just compromising the structural layers of the vessel wall. Now, my understanding is that this typically causes intimal hyperplasia, like the inner lining of the vessel thickens up in response to the inflammation.
Right, which narrows the lumen and usually results in an ischemic stroke or a cerebral infarct.
Because the vessel essentially chokes itself off. That's the standard progression, yeah.
Yeah.
However, the inflammation can degrade the media and adventitia so rapidly that the vessel wall simply loses its tensile strength altogether.
Wow.
So before it even has a chance to occlude and cause a stroke, the weakened wall just gives out under normal arterial pressure and you get a primary hemorrhage.
That's terrifying. Now, contrast that isolated central nervous system failure with the second type of vasculitis in our sources, which is polyarteritis nodosa, or PAN.
PAN is a completely different clinical beast. While the granulomatous angiitis is confined just to the CNS, Polyarteritis nodosa has this prominent, unmissable systemic involvement.
Like whole body symptoms.
Exactly. You aren't just looking at a patient with a brain bleed. You're looking at someone presenting with fever, severe malaise, weight loss, anemia, and a highly elevated erythrocyte sedimentation rate.
Because their entire systemic vascular network is literally under attack.
Yes. And crucially, PAN typically involves renal impairment, which is accompanied by systemic hypertension.
Okay, let me try to synthesize this for everyone listening, because visualizing the pathophysiology always brings me back to plumbing.
Go for it.
Okay, so isolated CNS angiitis is like a plumber discovering localized, really intense corrosion in just one single pipe under your bathroom sink, right? The rest of the house is fine, but that one pipe is rusting through.
Okay, I follow.
But polyarteritis nodosa is like a systemic rot affecting the entire house. It's not just the pipes.
No.
The main water heater is failing, the pressure is spiking everywhere, and the drywall is rotting out.
I really like that analogy, but we should push it just a step further to capture the clinical reality.
Okay, how so?
With PAN, that house-wide rot, specifically the renal impairment, is actually what creates the high-pressure environment that blows the compromised pipes in the brain.
Ah, I see.
The systemic disease actively feeds the localized intracranial failure.
That makes total sense. The kidney failure drives the high blood pressure, which then exploits the vasculitis in the brain. Okay, so if vasculitis is this intrinsic autoimmune corrosion of the system, let's pivot to the external hijackers. Because what happens when we introduce a chemical that forces a completely healthy vascular system to fail?
This brings us back to the string of pearls you mentioned in the intro.
Yes.
We are talking about sympathomimetic drugs. And the dominant player in this category, genuinely the most common sympathomimetic cause of brain bleeds today, is cocaine.
And the timeline for this is just brutal. The literature notes these bleeds typically occur within minutes to like a few hours of use, and they predominantly strike the subcortical white matter.
Right.
But I really want to dig into the actual mechanism of injury here.
Let's do it. So when you look at a cerebral angiogram of a patient who has just used cocaine, you don't see a single focal blowout. You see this dramatic alternating pattern across multiple arteries.
The beating.
Yes. Segments of extreme narrowing immediately followed by abnormal dilation. That's the beat it appearance.
And this is where that massive diagnostic misconception comes in, right? Because for a long time, doctors casually referred to this exact angiographic beating as vasculitis.
They did.
They just assumed the drug had triggered an inflammatory immune response that was physically tearing up the vessel walls.
And it's a completely understandable assumption based on just looking at the imaging, but opening the vault on the actual pathology tells a completely different story. Genuine histological proof of vessel wall inflammation in these cases is incredibly rare.
Like almost non-existent.
It is the absolute exception.
Because it's not physical inflammation at all, is it? It's multifocal vasospasm.
Right. The smooth muscle cells in the vessel walls are essentially being chemically hijacked. The sympathomimetic overload forces the vessels to violently clamp down and spasm, which creates those narrowed segments.
Oh, wow.
And then the interspersed dilated segments are basically just bulging under the transient spikes in systemic blood pressure. It is a severe functional reaction, not a structural inflammatory disease.
Which is terrifying because that sheer functional chaos can trigger multiple simultaneous hemorrhages. And the literature highlights a few different ways this actually leads to the vessel rupturing.
It does. In some instances, the transient extreme hypertension simply unmasks a hidden structural flaw that the patient didn't even know they had.
Like an AVM.
Exactly, like an AVM or a really small aneurysm. The pressure spikes and the weakest link just gives way.
Okay, but what about in patients without a pre-existing AVM?
Then you're often looking at a mechanism of severe vasoconstriction followed by sudden reperfusion.
Okay, break that down.
So the vessel clamps down so hard it causes microischemia, which weakens the capillary beds. And then when the vessel suddenly relaxes, the surge of high-pressure blood just blows right through the weakened tissue.
And the sources say this risk is also significantly compounded if the patient is concurrently using heavy amounts of alcohol, right?
Very much so. The combination is highly toxic to the vascular beds.
The idea of a chemical forcing our vascular system into this deadly spasmodic state brings to mind this incredible case study in pharmacovigilance from our sources, phenylpropanolamine.
Oh, PPA. Yeah, it is one of the most instructive historical examples we have of a chemical hijacker just hiding in plain sight.
Yeah.
For years, phenylpropanolamine was widely available as an over-the-counter decongestant and an appetite suppressant.
Which is wild to think about now. People were literally buying it off the shelf to lose weight or clear up a stuffy nose, totally unaware they were subjecting their cerebral arteries to the same physiological stress as a Schedule I narcotic.
It's crazy.
Yeah.
And the epidemiological data was stark. PPA was definitively linked to intracranial hemorrhages in young patients. We're talking about a median age in the early 30s, mostly women.
And crucially, these were patients with zero history of chronic hypertension. Yet when they presented with an acute brain bleed, about a third of them were experiencing sudden severe hypertension.
Right.
And their angiograms showed the exact same thing, that violent multifocal vasospasm.
It produced the identical beaded pattern. The chemical structure of the appetite suppressant was triggering the same unmitigated alpha-adrenergic stimulation as the street drug.
Wow.
The association was so undeniable that it led to a total withdrawal of PPA from the American market entirely.
It's just a sobering reminder of how aggressively the vascular system responds to sympathomimetics. But let's shift gears a bit. We've talked about structural autoimmune failures, and we've talked about violent chemical spasms. Both of those involve blood vessels bursting while actively trying to manage blood flow.
Okay.
I want to look at the third mechanism in our sources. What happens when blood is reintroduced to an area of the brain that has already died?
This is a vital distinction in neurology, and it fundamentally changes how we classify the injury. We are moving from primary ICH to what's known as a hemorrhagic infarction.
Okay.
While they both look like blood in the brain to the untrained eye, their underlying cellular pathology is entirely different.
So walk us through the sequence of events. A hemorrhagic infarction requires an initial ischemic event, right?
Yeah, yep. Exactly. It begins with an occlusion, either arterial or venous. The blood supply is cut off, and the downstream brain tissue undergoes ischemic necrosis. It basically dies.
Right.
But here is the critical part. The endothelial cells that make up the blood-brain barrier in that specific area also die. They lose their structural integrity.
Because maintaining those tight vascular junctions
Yeah.
requires energy. And without blood flow, there's no oxygen, no ATP, and the biological mortar holding the blood vessels together just kind of dissolves.
That is exactly the mechanism. So when the original blockage eventually clears, say an embolus just naturally breaks up and arterial pressure surges back into that necrotic vascular bed, those dead vessels simply cannot hold the fluid.
They just leak.
Yep.
Which perfectly explains the macroscopic pathology. Because the sources describe this not as a single expanding hematoma, but as a multifocal petechial hemorrhagic staining. It's like a seepage of blood speckled all across the dead tissue.
Yes, that's exactly what it looks like. We see this classic reperfusion injury most often in the setting of cerebral embolism. But the literature also highlights two other major scenarios.
Okay, what are they?
First, the reperfusion of border zone infarcts. These happen after a period of global hyperperfusion, like after a cardiac arrest, where the entire brain is temporarily starved of flow.
Right, that makes sense.
Right.
And the second scenario?
Venous occlusion. So conditions like a superior sagittal sinus thrombosis or a cortical vein thrombosis. In these cases, arterial blood is still pumping in, but the venous drainage is blocked.
Oh, so the blood just pools.
Exactly. It pools, it stagnates, the tissue dies from venous hypertension, and then the engorged necrotic capillary beds simply rupture and seep.
Okay, so clinically, if you're the attending neurologist evaluating a patient in the acute phase, distinguishing between a primary ICH and this reperfusion seepage is super critical.
Right.
And our sources provide a very clear checklist for this.
They do, starting with the clinical onset. A primary ICH typically presents with a sudden onset that progressively worsens, accompanied by prominent signs of raised intracranial pressure, or ICP.
Which makes sense mechanically. I mean, you have a localized arterial blowout pumping a massive volume of blood into a closed skull, rapidly increasing the pressure.
Right.
But with a hemorrhagic infarction, the patient's neurological deficit is usually maximal right at the onset.
Because the primary insult was the ischemic stroke. The tissue is already dead. They don't typically develop that severe progressive ICP profile, and you can almost always identify a distinct embolic source, like atrial fibrillation.
And the imaging distinctions are even more pronounced. On a CT scan, a primary ICH is a dense, homogeneous hyperattenuation. It's a solid mass.
Yep.
It has significant mass effect, pushing surrounding structures out of the way. It tends to sit deep in the subcortical gray nuclei, and it violently crosses arterial territories.
It acts like a localized explosion. A hemorrhagic infarction, however, tracks perfectly with the concept of seepage that you mentioned earlier. The CT shows a spotted, mottled attenuation pattern.
Okay.
Mass effect is mild or completely absent because the blood is really just filling the void of already dying tissue. It heavily favors the cortex, and most importantly, it is strictly confined to a single vascular branch territory.
Because it can only leak where the specific upstream pipe was originally blocked.
Exactly.
This distinction isn't just academic trivia. Misinterpreting this scan is one of the most dangerous traps in acute neurology.
It absolutely is, because if a physician looks at that mottled, patchy cortical scan and just casually labels it an atypical primary ICH, they are completely missing the mechanism.
They're treating the leak, but completely ignoring the fact that a massive clot caused the initial blockage.
Right.
If you don't recognize the reperfusion mechanism, you won't initiate the cardiac workup to find the embolic source, which means leaving the patient completely exposed to throwing another massive, potentially fatal clot the very next day.
Which perfectly underscores why we have to rely on mechanism-based diagnostics rather than just symptom management.
Exactly. Okay, to round out this deep dive, we need to cover the final mechanism in our case files. We've looked at autoimmune degradation, chemical vasospasm, and ischemic reperfusion. This last one is fundamentally distinct because it requires zero underlying pathology.
Okay, trauma.
Yeah, it is entirely kinetic.
We're talking about traumatic ICH. And you're right, this is purely the physics of an acceleration-deceleration injury acting directly on the brain.
Because the brain is essentially a gelatinous structure suspended in cerebrospinal fluid inside a really rigid, bony vault. When the skull experiences a sudden violent deceleration, like in a car accident, the brain continues moving forward due to inertia.
Right, and that kinetic reality dictates exactly where we see these traumatic hemorrhages, because the inner surface of the skull isn't perfectly smooth.
No, it's got ridges.
Exactly. The anterior and middle cranial fossa have sharp, bony ridges. So as the brain continues its forward momentum, the basal frontal lobes and the anterior temporal lobes violently scrape and smash against those bony prominences.
But the bleeding isn't just isolated to the point of impact. And this is where the coup and contra-coup mechanism comes in.
Right. The coup injury is the hemorrhage at the direct site of impact against the skull. But immediately following that strike, the brain rebounds through the cerebrospinal fluid and slams into the opposite side of the skull.
Ouch.
Yeah, causing a secondary contra-coup hemorrhage, which is often in the occipital regions.
So it's the brain acting like a kinetic pendulum, like a pinball bouncing off the bumpers.
Exactly like a pinball.
And this rebound effect is so crucial diagnostically. Because while chemical hijackers like cocaine cause multiple simultaneous bleeds through systemic vasospasm, severe trauma causes multiple simultaneous bleeds through sheer, bouncing physical impact.
Right.
The mechanism leaves a completely different geographic signature on the scan.
And that geographic signature, the presence of bilateral, multifocal contusions aligning with impact and rebound vectors, is the definitive hallmark of a traumatic etiology.
So, synthesizing everything we've pulled from the literature today for you listening, a brain bleed is never just a brain bleed. The exact mechanism dictates reality.
That is the core takeaway for anyone navigating this field. If you're dealing with polyarteritis nodosa, your clinical priority is managing systemic inflammation and renal failure.
Right.
If it's a sympathomimetic spasm, you're managing acute hypertension and monitoring for unmasked vascular defects. If it's a hemorrhagic infarction, your immediate job is hunting down the embolic source in the heart.
Yep.
And if it's trauma, you're managing kinetic swelling and physical shear injury.
It's all about looking past the symptom to find the true culprit. And I want to leave you with a final thought to mull over regarding how we actually identify those culprits in the future.
Yeah.
We spent a lot of time today talking about how human doctors looked at that string of pearls on an angiogram and mistakenly assumed it was physical vasculitis when it was actually a chemical vasospasm, right?
Right, a massive historical misdiagnosis.
Well, today we are rapidly training artificial intelligence to read radiological scans. But AI learns by analyzing millions of historical, human-labeled scans.
Oh, wow. Which introduces a fascinating diagnostic vulnerability.
Exactly. If the historical data is full of chemical spasms that human doctors mislabeled as structural inflammation, will our cutting-edge diagnostic algorithms actually learn to see the physiological truth? Or are we just teaching machine learning to permanently encode and amplify our own diagnostic blind spots?
It is a profound question about the future of medical imaging. Just because the computer says it doesn't mean it isn't still just a shadow.
The ultimate diagnostic, muddy waters. Keep digging, keep questioning, and we'll see you on the next deep dive.